All right. Welcome, everyone. Just going to let everyone kind of get situated as they come through the virtual front door here. My name is Eric Glazer, and welcome. You have logged in and entered into Bright Spots in Healthcare's live recording. This is a show produced by Shared Purpose Connect. We bring leaders together to not only inform you, the audience, but also unearth bright spots, success stories at health plans, hospitals, and various healthcare organizations around the globe. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared on our show can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective way to improving healthcare in our lifetime. I encourage you all, if you have not already, to subscribe to Bright Spots in Healthcare wherever you consume podcasts. That way, whenever we do a recording that's not live, or whenever we do a live show like this, you will get a version of that dropped into your phone or your tablet within about 36 hours of when we record, and you could be on top of all of the great content that we provide you by way of the experts we have the privilege of having on our show, like this all-star panel you have in front of you today. Our esteemed sponsor for today's episode is an organization called Healthy.io. They are the newest partner to the Bright Spots in Healthcare show, and we are super excited to be working with them. They are an innovative healthcare company that uses smartphone technology to make remote clinical testing possible. I will give you a few more details on them later on in the show, but meanwhile, as you are in front of your computer, you can certainly check them out at healthy.io. All right, let's jump into it because we have a ton to cover. My biggest fear about today isn't about all this great insights because we have a super panel. It's about keeping you all on time. So whole person care, how to effectively change the experience to both the consumer and the provider in treating and managing chronic conditions. That's what we're here to talk about, especially those ideas and the programs that have promise or are already working. And so our innovators and thought leaders in front of you today, representing 4 health plans and a digitally chronic care company, Healthy.io, they're going to provide you with all this information. We sent you their bios last night. If you registered late, you may have not received them. So Sherry Keels, our producer, just posted them in the chat. I have a second screen where my chat and Q&A module is, so that's why I'm pointing over here. So you could check out that link and get an idea of some of the great experience and insights you are about to receive. All right. In about 45 minutes, I'm going to send you another email. You're going to be asked for feedback. Those of you new to this show, we use your feedback directly to drive future programming as well as get better at what we do. We look at every single survey respondent. So I ask you the favor in about 45 minutes of looking at that email and filling out the feedback form. You could suggest future topics, guests, etc. In addition, I've never done this before, but I came up with this morning. So if those of you who want to be talking to me about content and what you think we should be covering and have suggestions for panelists, especially those of you who represent payers and providers, Sherry's going to put up a poll if you want to set up a one-on-one with me, and then my admin will reach out and schedule something over the next 3 to 4 weeks where we could talk one-on-one for 30 minutes and discuss meaningful things around healthcare and what we should be talking about as an industry. That allows me to really hone in on how we could best serve all of you each and every week. Furthermore, if you're an organization that markets into the payer and provider markets and you want to be up on a panel like Healthy.io is today through sponsorship or partnership with us, I'd love to talk to you about topics as well. We just have an informational call, so you can click on yes too, and we'll set up time for us to speak. All right, let me now I'm going to bring in our first panelist. I'll introduce them by name, title, and affiliation as I bring them into the conversation. But I want to start off with talking about the most effective ways of integrating chronic care management into the primary care setting, because I think that will set the stage for the rest of our conversation and where we'll go. And by the way, there's a Q&A module, folks, at the bottom of your Zoom platform. Those of you who are new to Zoom, I doubt many of you are at this point. Please use that to submit your questions. I'll do the best I can to incorporate them into our conversation. Granted, we're tight on time today, but use that, not the chat. because that's the only way we're going to be able to manage it effectively. So integrating chronic care in a primary care setting, I'm going to bring in Dr. Ken Snow. He is the clinical portfolio medical director within the transformation team at CVS Health. Ken, talk to us a little bit about some of the effective ways you see from where you sit on how to best integrate chronic and primary care together.
Good morning, Eric. One of the first things we think about is how are we interacting with our populations? We need to think about how are we going to communicate with the physicians that we will be interacting with and whose patients, our members, will be managing or co-working with, so that we wind up being in addition to them, that we wind up being helpful to them. We certainly don't want to be in competition with them, and we don't want them to perceive it that way. So communication with the provider is key, and communication with our member, effective communication, so that they understand where we fit into the picture, so that we can help coordinate various issues for them, is really the way that you can change behavior.
I'm going to bring in next into the conversation Dr. Jonah Mink. He's the medical director at Healthy.io. Jonah, from your perspective, you get to see a lot of different organizations in your work. What are some of the most effective ways of integrating chronic care management into primary care?
Sure, thanks, Eric. So I have a kind of a dual perspective on this. I'm the medical director at Healthy.io and also a family physician. So I see it in the clinic and also from the organization side about how we can do this most effectively. And what I've seen so far, really, it's about the people at who are the targets, meaning there's so many data points coming all the time, right? There's so much data coming at a physician throughout their day in the clinic. There's so much data and information and different stimuli vying for the attention of both the patient and the doctor, both within the clinic and outside the clinic, for the other 50,000 hours that the patient is not in front of us, there's no way to compete with that, right? The only way to think about this is to join the life flow of the person that you're addressing. Join the life flow of the doctor, the clinical flow, the life flow there. Join the life flow of the patient. Fit into their speed of life, right? At Healthy.io, that's kind of our motto. How do we fit into the speed of life in order to kind of join them as they go through their day? And that means, for instance, in a clinical setting, a random pop-up in an EMR that doesn't lead to an actionable event in that moment is very difficult to deal with. It's annoying. We don't want to stimulate the doctor to be annoyed, right? We want them to be able to take action on when and what is being surfaced to them at a given time, right? So when the patient's in front of them, if the appropriate alert comes up, that's actionable, right? If they're going through their list of results and in the mode of calling patients to talk about their results, that's an actionable moment. So that's the type of, those are the moments when their attention is oriented towards what we're telling them. And as things go virtual, as things are more and
Lost you there, Jonah. I kind of saw where you're going.
I'm gonna appropriate time.
Hey, Jonah, just
yeah.
we lost you there for a few seconds. So I think we're good.
Oh no.
Yeah. Did you want to continue on that?
So smart.
Yeah, I'm sure you were. So you say now, if you want to continue, if you want to kind of rewind 10 seconds, I'll let you go there.
Yeah, sure. So I'm not sure where you lost me, but pretty much my point is that when you're able to surface the information and the actionable insights, the actionable data points at the right time, both for the patient, whether it be on a smartphone app that they have fun using, that gives them a notification at the right moment in their life, that walks them through taking their blood pressure or stepping on the scale or whatever the data point is that is most crucial at that moment, for them to capture the data. And then the same thing, keeping the doctor and the whole person kind of at the center of the intervention, that when it's most appropriate for them to see that data point and act on it, that's really the key to enmeshing and keeping the connection between the doctor and the patient solid between clinic visits and gaining these insights at a population health level. It all starts with how you capture that data and how you act on the data.
Yeah, it's actually a really good foundation because we're going to dive into different parts of the points that Jonah just made around not only diving implementation and engagement, but also diving into the data. So I think what I'd like to do, like, I want to talk a bit about best practices and get into some of those practical ideas and how to do this. But let's take a moment. We're not going to dive into, like, folks, we're not going to spend a whole lot of time talking COVID here, but I think it is the elephant in the room and how COVID has obviously mobilized the entire planet into this digital interface. So let's talk. I'm going to bring in Caroline Carney. She's the Chief Medical Officer at Magellan Health. And Caroline, what are some of the best practices around chronic disease within this new normal that we're in?
So I'd like to build on something that Jonah mentioned. He focused on the interaction between the patient and provider in the office setting or in the office encounter, even if that's telemedicine, that type of encounter. One of the things that we have pivoted toward at Magellan RX and in Magellan Health is really to support both that provider and that member outside of the clinical exchange in reaching those individuals in other ways to provide supports for getting the best care. So that elephant in the room, COVID, there's never been a more ideal time to really reach out to people and provide them supports during all those other hours. We have a program at Magellan RX Management called the MRX Cares Program. And it's a program for individuals who are on specialty drugs. These individuals have conditions like cancer, like MS, like HIV/AIDS, or other really significant conditions requiring specialty drug treatments, and often conditions that have an immune component to the care that they need. And so during COVID, this was a group of individuals who were at very high risk for social isolation. And we know social isolation, very common with COVID, already common in this population as it was. So imagine mixing that kind of condition together with COVID. So we decided to do an outreach program to provide better support and to combat social isolation and loneliness that those individuals might have. We used a text messaging program that was more than just text messaging, but then provided links to other kinds of supports and services that touched on all sorts of issues that were important to individuals who might be lonely or have social isolation. We reached over 1,700 individuals and saw a very low dropout rate, which occurred mostly in the first week. So for about 85% of the individuals who were enrolled, they stayed with us the entire period of this program. And we had some great results and some findings that were really concerning along the way. So the satisfaction rate with the program was at 90%, which is incredible to see a text messaging program with that kind of acceptance and that kind of positive feedback. But what's concerning is that we found that 17% of the individuals who were socially isolated reported that they had no one checking on them, no one ensuring that they could get their medications, no one doing the kinds of reach-ins that would support that individual in their life and their disease journey. So right away with this kind of pilot, we're able to say, okay, this group of individuals needs additional outreach from our nursing team, from our social work team, to really provide them the supports that they need and ensure that they're getting food, that they're getting their medications, that they're getting transportation to visits or have the ability to be able to link into a telemedicine visit with their providers. So really critical stuff that we learned with a simple text messaging pilot. And what was even more exciting to learn is that there was no difference in satisfaction between the age group bands. So if you were someone in your 20s, you found this program just as satisfying as someone who was in their 60s. But there was one difference. And the group that found the program the most helpful were those individuals who had the highest burden of social determinants of health. And that's the group that we really want to reach. So the group that found it the most helpful and got the best use out of the services that we were providing was really the group that needed it the most. So it was a huge win for this program. and one that we're now continuing even as COVID goes away and individuals are able to get out more and live their lives more. We know that we've identified a group who really needs this kind of service and are going to continue it into the future.
And would you say that was great? And would you say this MRX program, the key to it is knowing the pharmacy data, so you could focus in on the individuals who are highest at risk, and then having a well thought out engagement plan? Are those the two? Like as I'm thinking about the audience,
Yeah,
trying to figure out how to execute this. Yeah.
Absolutely hand in hand. So both on the Magellan RX Management, our PBM side of the house, and the healthcare side of the house, we've really had a transformation in the way that we do chronic care management and case management, which is a very data-driven process. We use a data partner, a company called Arene, in getting to the right populations. And it's a statement that I've been saying over and over, but there should never be a homogeneous approach for a very heterogeneous population. Inside all of our populations, there is a different set of needs, group by group by group. And so our programs now, using that kind of data structure, are very targeted to reach the right group with the right intervention.
Could you, because I know Sherry wants to put this in the chat, can you what's that organization you use, just so folks could check them out?
Arene, ARINE.
Awesome. So what other programs are payers? I want to learn about other programs other payers are putting in to facilitate this whole person chronic care initiative. And I'll bring in Ellen Beck-George. She is the Associate Vice President of Pop Health and Clinical Transformation at UPMC Health Plan. And then we'll put, Terry, we'll put you on deck. So go ahead, Ellen. What are some of the other programs that maybe that you guys are working on in the same vein?
Sure. Thanks, Eric. Appreciate the opportunity to share that. So I'd like to talk about the digital translation of a myriad of our telephonic condition management programs that we've had in place for a long time. So we've built a platform at UPMC Health Plan called RxWell that lets our members access evidence-based behavioral medicine interventions for behavioral health and health behavior change. And we made that transition prior to the pandemic, but of course it's been really wonderful to become more digitally enabled during this time. And we made that move really for 4 reasons. The first builds on what Dr. Carney just talked about with the high rate of satisfaction with the texting program. We know that digitally enabled communication is the preference of our members, and that's how we'd like to communicate with them. We also know that we can scale and deliver more service digitally than we can telephonically or face-to-face, and it lets us keep a very close eye on the quality of the service that's being delivered. So at UPMC Health Plan, we heavily emphasize motivational interviewing as a core competency for all of our clinical operators. And by having this text-based communication through the RxWell app, we're able to select a random sample of those exchanges continuously and code them for evidence of MI competency. And we have a mentoring and feedback program that continuously runs to ensure that our clinical operators are at a very high level of MI competency. But finally, health is lived every moment of every day. And so the digital channel, mobile apps, right, these are just better positioned, I think, to have impact with people over time than more episodic interactions telephonically, face-to-face. Those types of modalities obviously still play a major role and augment what we do digitally. But we think that the opportunity to provide a little support a lot of the time is just more aligned with how behavior change and health improvement happens than a lot of support a little bit of the time. And so we've had good success with RxWell. More than 50% of our members who are using it see significant improvements in symptoms related to the driving reason for them to use it. Over 2/3 are hitting our engagement target around how much of the app they access and how long they stay engaged. So we've been very pleased with the product so far. We continue to scale it. And I know when we spoke, Eric, I did want to mention that, of course, the member-facing aspect of RxWell is critical. But at UPMC Health Plan, we've really doubled down on human support delivered through a digital channel. So RxWell is a digital service that members can use without the support of one of our digital health coaches. But we attempt to engage them with our digital health coaches. And so the informatics platform back end of RxWell, our coaching dashboard, if you will, is really what is enabling us to scale evidence-based service and to scale meaningful relationship building. So I know in the digital health realm, we talk a lot about the consumer-facing portion of these digital tools, which of course is critical, but it's also so important to ensure that the informatics backend is supporting scalable, tailored, evidence-based service delivery.
Like that. So I heard a couple of key components here. If I could just summarize, make sure we got this right, Ellen. I mean, obviously understanding that the preferred consumer experience as a whole is mobile digital. I want to go back there in a moment. You need to be able to create scale here. You need to be able to track it, and you track it in both from a consumer perspective, but also as how well your team is using motivational interviewing to engage and to collect information. Did I capture everything there? Are those kind of like people listening, taking notes, thinking, how could we do this at our organization? Are those some of the key kind of foundational pillars this is built on?
Absolutely, with respect to the process, but I think the key component of the why, again, is that, because the health is a lived experience, that is the product of choices we make every moment of every day, and we know those choices aren't equitably distributed, but they are a function of how our health kind of moves in a good or bad direction, that the ways that we can communicate more consistently, more frequently, in a more targeted way through digital tools, I think lends itself better to trying to support people to better manage chronic conditions or achieve health behavior change.
Ellen, do you have any, what about the folks that aren't really, they're not pro-digital, or they just don't have access to the dexterity, or they're cognitively maybe a little bit disabled? Do you have a plan for them? I know we didn't maybe talk about that pre-show, but.
No, sure, I'd be happy to speak to that. I can say that in a couple, maybe three ways. One is that there will, certainly still, and for a long time, there will always be a portion of a population that would prefer to have service telephonically or face-to-face, right? And so we're not letting go of those operational capacities. Second, I really appreciated Dr. Carney's description of the text messaging program. I think text messaging is an incredibly powerful medium for assessment, outreach, and service delivery. You don't always need a full-scale mobile application. There's so much that can be accomplished through texting alone, which is sometimes a little bit more accessible to folks. And last but not least, in some research that we've done at the health plan, we've found that if we provide some high-touch support at the beginning to onboard people, tech onboarding for folks who maybe haven't ever used a smartphone or aren't digitally native, with really just a couple of hours of focused support that can be done in person or even over the phone. And we found that once we can get people over sort of that initial hump of the learning curve, that they are well equipped to make full use of the digital tools that we are making available. But we do think that this tech onboarding is certainly a new function. It may represent an opportunity for a new workforce capacity, because we don't have to have our care managers, our nurses, our social workers doing this tech onboarding. But it is an important part of digitally enabling our care management services.
I'm sorry, it was your social workers doing the text onboarding, or you had a different team doing that?
No, I'm pointing out that tech onboarding is an important function as you work through digital transformation, and it's a workforce that shouldn't leverage our expert nurses and social workers and care managers. Like a very different level of operator can do a wonderful job at that task, and so for efficiency, we've kept our clinical operators protected to deliver service and have looked for other operational capacities to do things like tech onboarding.
Got it. Are they also trained on motivational interviewing, or are they more just focused on communication with the technically challenged?
Yes, we really believe in motivational interviewing and have scaled the competency development across our entire clinical organization. So anyone who has a member-facing role has an opportunity to go through MI training during onboarding and competency development over time.
Awesome. I'm gonna bring in next Dr. Teresa Koenig. She is the Executive Vice President and Chief Medical Officer at Medical Mutual. And Terry, I'd love for you to talk a little bit about how you guys approach it strategically with just how you interact with your provider partners. And then if you had a program or two that you're also doing, we'd love for you to share it around.
Right. I mean, it's great to hear. You're going to hear, the audience is going to hear a lot of recurrent themes that we're all doing. We built our care continuum population health model where to meet the member wherever they are. We have our own wellness company that has digital engagement tools. We actually have a gaming tool app that they can answer gaming questions. And, we also then have email engagement, person engagement. But we also know that people enter the healthcare continuum at various different places. And like Dr. Snow mentioned, we try to partner with our health system providers and our individual providers, not compete. So we will work with them to supplement that continuum. So for end of life care, for example, if a health system has a great palliative care program, we'll use that for the attributed members and not use a vendor program. We've also had a lot of success using digital AI with home monitoring for rising risk. So those who need lifestyle coaching as well as diabetes or hypertension, we're using a vendor called Lark right now. That's an interactive AI with the patient where on their terms, they can monitor their blood sugar or their weight or their blood pressure. We then also don't want to overwhelm our provider partners. So we have touch-ins with the providers only when that provider wants it or when it's needed. For members that have pound out of that, so they want a live person or their clinical needs are obviously much higher, we have live persons to do that as well as video chat for those patients. And we're so much not competing. We even do discharge programs we do our own predictive analytics to stratify who's going to be that readmission. Maybe they don't know it, but maybe we predict it. We'll use community agencies like the area agencies on aging in partnership to make those visits instead of using someone else. So we're all about working with the healthcare systems that exist. Even with COVID right now, we've risk stratified our highest risk Medicare patients, and we're working with the health systems. All right, we're going to call these 5,000. You want to call that 1,000? They're yours. So it's really that partnership you've heard people talk about, as well as meeting the patient where they are, whether it's technology. If there's a digital divide, then it's, however you can engage that patient. It's about communicating with them and helping their provider deliver the best care that's possible for their situation.
Yeah, I mean, I think there is a whole show on being able to be innovative and resourceful with the resources in your local market and leveraging that. Maybe that's a whole show. Sherry, take a note of that. But yeah, I mean, I think that's really interesting and fascinating. Sounds like you're doing a lot of really good kind of groundwork, good work there, leveraging new technology and just pragmatic usefulness of resources that already exist. Folks, we have a lot to cover here. We're going to jump into in a moment a little bit around process, and we're going to get into analytics and impact as well. Before we do so, I just want I mentioned to folks at the beginning, if you join us late, Healthy IO is supporting this week's episode. I just want to tell you a little bit more about them. I mentioned that they're a leader in turning the smartphone camera into a clinically graded medical device for at home, being used by leading healthcare systems throughout the world right now. And they've been recently featured on CNBC, Fast Company, and the Financial Times. And they're now, get this, they're being used by the National Health Service in the UK. Those of you probably know, they're like the CMS Plus for the UK. And that's because of the test's ease of use, the high percentage of adherence by patients who have been sent the kit or downloaded the app, and also the huge savings that are associated with the test itself. So they are the first company to convert your smartphone into a clinically graded medical device to enable at-home testing. So I wanted to give them a shout out. Super excited that they have been part of our family at Bright Spots in Healthcare, and we've gotten to know their team and what they do really well, including, of course, Jonah Minnick, who's right in front of you. He's been great to work with on this. So they're doing a lot of work to support diabetes and reduce the risk of CKD using this technology. And if you guys want to meet them, their senior team, during that survey that's about to come out in about 15, 20 minutes, I'm happy to make a one-on-one introduction just so you can learn a little bit more what they're doing and how they're driving consumer engagement and consumer utilization of this kit and how they actually interact with the physicians that take that data. They've got some cool stuff. You don't need to necessarily buy their services to have a call with them. So let me know through the survey if you want a personal email from me introducing you to them. I'm happy to do that. Also, Jonah, Sherry, why don't we grab this up another poll? Jonah recently posted an article on Kevin MD, that well-known blog, on how primary care isn't broken, it just needs a better support system. It's a pretty good article. It's not a promotional piece. And why don't we put that up? If folks want that and they don't have to download or fill out a form to get it, we'll just send them the PDF in an email. So we'll put up a poll right now, and if you guys click yes, I'll email you directly a link to that article as well. Let's talk about, actually, I'll bring in Dr. Ken Snow. Let's talk about chronic care vendors. Let's talk about them in front of their face here. What's a pain point you don't see today's chronic condition management vendors addressing right now, Ken? Oh, you're on mute. Sorry. Happens all the time. Happens all the time.
So traditionally, thank you. Traditionally, we've been in the area of coaching and in sort of task-based things. And we've been there for a good reason. These are very important. So, the task-based, have you had your X, whatever it may be, test done, or have you had this appointment, or, have you had whatever procedure screening, test done? And as I say, we recognize the importance of these and the coaching aspects of lifestyle and taking medications. But where it's then stops is, what about those folks who are taking care of those issues, or where those are not these significant aspects of what's limiting their care? And we have such an opportunity with the wealth of data that we now possess to be able to say, what is the next best action in their care that should occur? And particularly we see in the management of chronic illness, the issue of clinical inertia, where the next best action is that the therapy somebody is taking is no longer adequate, or not working, or not working optimally, and that there's an opportunity to move on to the next therapy. But when we look at this issue, traditionally, clinical inertia has been a problem recognized for decades, with really has been a very difficult nut to crack, that this is not a new problem being identified. And yet there has not been adequate solutions to allow patients to be able to move on to those therapies in a timely fashion as they need them. And so in various conditions, whether it's diabetes or hypertension or hyperlipidemia, the patient continues to live on a suboptimal therapy, being adherent, doing what they should do, but on a suboptimal therapy, so that they are at risk of the complications and adverse events that occur from those conditions because of this inadequate treatment. And we have the opportunity now to identify those folks and to intervene, to be able to inform that patient of the opportunity that exists for their care, to be able to work with their provider to identify folks who could advance forward, and also to help with what's the optimal next step in terms of therapy.
Ken, do you think it's pure clinical inertia, or is it also they're not taking into account some of the the social determinants we all talk about now that's so important, housing, food, etc.?
There's no doubt that social determinants play a very large role in this, both in terms of access to care and just the availability of somebody to be able to, even if the care is accessible, their own availability to be able to access that care. If somebody needs to take off a half a day of work to be able to get a particular test procedure, or to get an appointment with a physician for the sole purpose of adding a new medication, that's far less likely to occur in somebody who is a day laborer, and to take off a half a day of work means we've just cost that person 10% of their weekly income.
Yeah. Let me, so I'm going to bring in the vendor here. So Jonah, what is, not talking about you guys specifically, but, what would be your 2 cents on how, what's the pain points you don't see that, the vendor community, the innovator community is missing here around chronic conditions?
Yeah, it's a great question, and I would echo what Dr. Snow said 100%. I think that the two pieces that need addressing, they need a little tender, loving care, is the social determinants of health side and the clinical inertia. And I think that what you're able to do in your organization, Dr. Snow, with the massive amounts of data to inform where you apply your energies, about how you're going to attempt to change that, to move that inertia forward a little bit, is very interesting. And my perspective on this is, where's that data coming from, and what is that data, right? Like, is that data the right data, right? When you're a payer, when you're a large institution that's getting massive amounts of data from your vendors, right? From the actual point of care, from that blood pressure cuff, from the glucose monitor, from the urine stick, from the different blood tests, and you're kind of aggregating it all together. What are the insights based off of that are actually driving care? And are those data points and those insights actually correlated most efficiently with the health outcomes, right? And I think, I'm really very rarely one to put in a baseball analogy, but it's almost the kind of the Moneyball effect in healthcare, right? And it's the classic way that we look at the data that's coming in. It may not be the best way for us to determine the best action to take, right, on a large scale. So I would say that when you're working with vendors, when you're working with different vendors, and it's something that we put a premium on, is what is the evidence base? What is the best evidence for tying most efficiently the analytes and the biomarkers that you're measuring with the outcomes, with the cost outcomes, with the health outcomes? For example, in kidney disease, traditionally, there hasn't been a lot of clarity, especially on the primary care side, and especially among patients. I mean, 77 million Americans at risk of chronic kidney disease, and only about 20% of them are doing the recommended annual urine screening, right? So and me as a primary care clinician, the mantra, I'm trying to keep track of a million things with my patients with diabetes, but one of them is make sure you monitor their kidneys. What does that mean, right? Traditionally, doctors would answer you, primary care doctors, well, it's usually around their serum creatinine, it's around their glomerular filtration rate, try to say that 5 times fast, and that is the measure of kidney disease, right? And that's what we traditionally do, that's what's done at a very high rate. But is that really the best measure by itself of their risk for end-stage renal disease, for cardiovascular outcomes, for cost, right? And it turns out, when you look at the evidence, it's really not. You really need the matrix now, and there's a big push by the National Kidney Foundation, the American Diabetes Association, to really kind of frame this a little bit more evidence-based. So maybe I would say that, along those lines, pushing your vendors to make sure that they are bringing you the data. They can bring you data all day long, but if that data isn't correlated with what you care about, then it's not worth that much, right? And so when you're able to correlate the albumin creatinine ratio with the GFR in the right matrix, you're able to risk stratify your patients with diabetes or other patients at risk of kidney disease in a way where you're able to tailor these interventions. And like you were talking about, Dr. Snow, tailor the right next step in care to what it actually makes an impact, where that person is in their course of disease, and really kind of avert those inevitable outcomes and make them less inevitable for these patients. And I can bring another example, but I don't want to take too much time here, Eric.
First of all, I love Moneyball is a great book. If you haven't read it, it's not a baseball book, folks, even though it's about baseball, it's a business book. That is fascinating. So maybe we were just picking the wrong data points to pay attention to. I know Dana had sent me a paper that you guys had and for those of you who are not medical leaders on the call right now and want to better understand this, I wonder, Sherry, if we put up another poll, because I think, Jonah, keep me honest here, that piece will allow folks to see some of those data points that you're suggesting, even though it's not in the same frame, frame that you just put it in. But so if they miss some of it, or they want to forward it to a colleague with a medical degree at their organization, maybe that's the best way of doing it, is letting them. Why don't, Sherry, you put up a poll? Anyone that clicks yes, we'll same PDF, we'll just email it to you. You don't have to fill out a form or anything, and you could see some of the data points. I think it was, Jonah, do you have the page? You were referring, is it 10 or 11?
No, it's a good question.
It's page 11.
Yeah, I think it's around page 11 there. And I think what you're referring to, Eric, is really that graph kind of that shows the difference between GFR and ACR, the albumin creatinine ratio and the glomerular filtration rate, and kind of at what point in disease are they going to be, aberrant when kidney damage happens? And it's fascinating, right? I mean, it's really interesting, even for the non-medical folk, that like when you see a decrease in the GFR, which is the blood test, which is traditionally what we think of as the screener for, in primary care, at least for kidney disease. That's only after the kidney is unable to compensate for all of the damage that's been happening to it over time, right? So when you're able to bring in the ACR, which is a direct measure of the permeability, the kind of the leakage of things that shouldn't be leaking in the kidney, and you're able to correlate both of them, there's excellent, robust data supported by KDIGO, which is kind of an international consortium of researchers, that shows that it's when you're able to kind of relate both of them to each other, they can very accurately predict negative outcomes. Whereas using each one alone is not as fine of a resolution. There's a similar correlate with wound care. We work in wound care as well, and wound care is a very kind of complex and disjointed process, and a lot of that burden falls on the patient trying to see their wound specialist and their primary care doctor and their nutritionist. And what do you measure there, right? What is the biomarker that you're looking for? And it turns out that if you are able to accurately monitor your wound itself at home, it can give you a very interesting and accurate representation of what that person's risk is for hospitalization, for decompensation, just by understanding, is this wound healing, or is it stagnating, or is it getting worse, right? And by being able to measure that accurately, you can really get an amazing sense of, is that person sugar controlled? Are they getting enough blood flow to that wound? Are they getting enough nutrition, right? And by using these kind of creative surrogate biomarkers for chronic disease and other metrics, you can really tie the evidence base to the outcomes, both morbidity and cost.
That's great.
There's also the opportunity of sort of non-traditional markers. So even moving beyond biomarkers, there's what correlates exist that we're not even yet aware of, that the ability to bring in lots of data almost on a snooping exercise that we're not sure A correlates with B, but if we look, we may find some surprising correlations that are not the traditional ones, that are not necessarily just biomarkers, but may have more to do with whether it's social determinants of health or other factors in people's lives that correlate with their behaviors, and that those behaviors in turn then correlate with the condition we're looking at. So the opportunity to look at to collect a lot of data, to be able to start asking not just the traditional questions, which are really helpful regarding biomarkers and what correlates with disease progression, but also some non-traditional markers that may correlate as well, and to start collecting those in particular disease states.
God, we should probably we should talk about, maybe there's a forum we could create, a consortium we could almost create for this. I love the whole theme of trying to reinvent what data points really matter. I think it's an important point that was made in Moneyball and really hasn't transferred itself into the clinical arena, although it's been very effective in changing other businesses and having other businesses really take an inside out view on, like, are we really looking at the right metrics? We could talk the rest of the way here. I'm looking at the time. I want to move on. I want to get into how the providers are important in this process and how health plans can better support them. because they're often not the one, right? Health plans and the providers in the trenches. So I'm going to bring back Ellen Beckjord, because even though she's at UMPMC Health Plan, obviously they're very closely aligned with UPMC. So how are you guys doing that over there, Ellen?
Sure. So for more than 5 years now, we've been using an initiative that we call Prescription for Wellness that lets any of our network providers, primary care and specialists, prescribe the clinical services that we can deliver at the health plan for their patients who are our members. And it's, been done a people process technology initiative. We've thought very carefully about how to make the referral process, the prescribing process, as seamless and easy for providers as possible. But they can prescribe the full spectrum of our services, whether it be our behavior change services, our behavioral health services, services that we have in place to help members access social services to address social determinants of health. It's been hugely successful with respect to engagement. So when the trusted entity, the provider, prescribes these services, we see about a 300% engagement bump with respect to being able to reach our members and engage them in our services, as compared to when we cold call outreach to them. We know the providers are the more trusted entity, and we know that despite our continuous and best efforts, our members aren't always aware that their health plan provides this spectrum of services. So if folks are interested in learning more about Prescription for Wellness, we published several papers on the initiative, and we're grateful to recently receive a Paper of the Year award from the American Journal of Health Promotion, where we most recently published the results of our work with Prescription for Wellness.
Wow. Is there anywhere we could link or post a link there, Ellen, or not? No. To get to any of the studies?
I don't believe that. I can, the most recent publication, I don't think is freely available, but one of our earlier ones maybe, and I'll be happy to follow up and send that link to you.
Okay.
Eric, if I can just share though, if you're not aligned with the health system, that level of communication with the providers is still extremely important. And we have joint operating committees, even with smaller independent provider groups on a regular basis. So we can share the data with them, our programs, have them give us feedback, what's not working, what is working. And then we do joint outreach to patients or campaigns. So I love what you're doing at the Align system, but I think it's important for plans that work with all providers to still put that effort out and do that kind of work.
So Terry, you teamed me up great, because there's a question from an audience member for you that I was figuring out how to get back there, and you did it perfectly. So I'm going to ask you a follow-up to that.
Okay.
Getting back to sort of, preventing readmissions and in so much as partnering with the providers, what do you do with the information, that you're capturing for high risk readmissions? And if a patient is flagged for rehospitalization, do you have the action steps? What are the action steps to partner with the provider? Yeah. So could you explain that?
We actually have a home visit done within several days of the discharge. We do med rec. We make sure that patient is scheduled back for their provider, whether it's their primary care, which is always our choice, as well if there's any specialty visits. And then we get that information that triggered their risk status to the primary care for that visit. And then we continue staying in contact with that patient for 30 days. Our team communicates with the program sponsors our community agencies we use, because we think it's important. Like you said earlier, we try to use what's already in the community in new and different ways instead of bringing in external people.
That's great. I'm going to, in the interest of time here, jump around here. I want to talk about predictive analytics. It's been brought up and been an underpinning of a lot of your answers here. So I'm going to bring back into the conversation Caroline Carney at Magellan. Caroline, what are some of the most innovative and effective ways that predictive analytics can leverage an impactful and create an impactful program? I mean, how do you use it to create an impactful program, or an example you may have?
Yeah, I would love to talk about one that we are engaging in with predictive analytics. So using the company that I referred to earlier, Arene, working with Arene's CEO and team, we have put together the use of predictive analytics to model individuals who are at highest risk for suicide. And it's really pretty fascinating because depending on what data sets you have, the coming into the predictive analytic tool, the models can get very, very precise about who's at highest risk. So whether those are medical claims indicating any past attempts and any of the medical sequelae of attempts, whether those are behavioral health claims, or whether those are pharmacy claims for individuals who may have never touched the behavioral health system, we can still learn a lot about those individuals. We also pull in health risk assessment data, social determinants data, and in a continuous learning model, ARENE constantly is producing this risk list for us. So we use that predictive analytic technology to then do many different activities with it. The first is taking the list of those individuals who are at high risk and engaging them through the kind of reach-in programs that we have. So whether we can reach into a primary care provider and alert the primary care provider about the risk, or whether we do phone calling or peer visits to that individual to reach out to those individuals who are at highest risk to try to engage them in care at that point. On the back end of someone who may have come into a behavioral health hospitalization with a suicide gesture or suicidal ideation, we then know that we can reach back into the data and understand that person's risk and wrap the right level of care around that individual. So for instance, the 2 weeks following discharge from a suicide attempt is the greatest risk period for an individual actually completing suicide. So during that 2-week period, putting the right set of services in, whether those are peer visits, whether those are getting into more intensive psychotherapy initially, whether that is in partnering with primary care or other care providers across the BH system. The idea is really wrapping the right set of services around individuals depending on what their risk is. So those analytics drive what happens on the front end in terms of outreach and on the back end. We further are working with an organization called NeuroFlow. NeuroFlow is a collaborative care company based using data science to really support primary care or other providers in getting behavioral health care right, using behavioral health support services in the background. But one of the technologies that this company has is an app-based support that really supports the member between visits. And every time that individual interacts with the app, the AI with the app is collecting information that populates a dashboard. So we can see if an individual is engaging in less activity, is looking up articles related to suicide, is scoring on assessments and gamification activities in the app in ways that would suggest that depression is getting worse. And so that is triggering a dashboard in real time, again, alerting our case managers and the primary care providers to an individual whose risk might be rising for suicide. So putting that app into the hands of high-risk members is a critical initiative for us.
Can you repeat the app name one more time for everyone?
That company is NeuroFlow.
NeuroFlow, okay.
Yeah. And they have become so successful at what they're doing that the United States military is partnering with them. They have contracts with the Air Force as well as a new one with the Naval Academy to engage in that kind of suicide prevention activity. So this idea of starting with predictive analytics, finding individuals before an event happens, if an event does happen, then putting the right services in their hands at that time and using the kind of app-based support throughout to extend what an individual is able to do. Obviously, we can't have an individual with someone 24/7, but with the app-based support, we can really get to wrapping the right sets of services around those members.
Cool. I'd love, I don't know, Terry, if you have anything to build upon on that. And I want to bring in Ellen right behind you to talk about how this data is being used to model and reimburse tied to value, clinical goals, et cetera.
Just really briefly, similar to the AI, we just did something and we're doing it with our health system providers of our Medicare enrollees at highest risk for COVID. who have barriers to the vaccine. So we took all the social determinants, isolation, medical desert residency, and we've come out with a risk score. And right now we're working with our health systems. How do we get these people vaccines? We're working with our local 211 for transportation. So again, using what we have, but bringing in that AI, because we're not looking for the 66-year-old who's, playing tennis and driving around. We're looking for that high risk senior who can't figure out how to use these vaccine sites to get themselves set up. Similar concept, different goal.
Like that. And Ellen, what about tying it to reimbursement?
Well, I think that, a lot of the services that we're talking about that really distribute, one might say democratize care delivery, but certainly distribute care delivery across new settings, new modalities. I'm not sure that the payment models have quite caught up. I think that's a really active and exciting area of healthcare right now. I think that the tide has turned, even with respect to major changes in telehealth delivery and availability that we've seen during the pandemic, which was one of the only bright spots of the pandemic. But I do think that our reimbursement policies, our payment models, and how we think about incentivizing care delivered outside of a brick and mortar doctor's office is a really exciting and active area of inquiry and health services research and in healthcare delivery, and critically important.
I think that CMS has done a great job of promoting the use of telemedicine by changing policies around that. And in particular, in the collaborative care area, the proactive use of codes to be able to bill for collaborative care, both from the primary care side as well as the psychiatric side, has been a big forward step for that program.
As with new codes for billing around addressing social determinants of health, I think we're catching up with reimbursing providers for delivering care in ways that patients want and for things that patients need.
Caroline, I just want to rattle off a couple of audience questions that are addressed at you. One, could you help folks level set as far as Magellan and the RX group as being commercial Medicare or Medicaid? And I'm going to ask you a second question is how are you getting that data from patients to know that a person is at risk for suicide? So two questions, unrelated, but both to you.
Sure. So on the RX side, Magellan RX management is in many spaces, including state government, commercial, exchange, Medicare, and Medicaid. So we serve all audiences through Magellan RX management. With the suicide question, wherever we can get data from individuals, so whether we have medical claims coming in, behavioral health claims coming in, utilization management data coming in, pharmacy claims coming in, health risk assessment data coming in, even information from health information exchanges coming into the ARENE system, remote monitoring data as well. All of that can come into the system to get into the predictive models, whether those are for risk for high levels of utilization or suicide or lack of adherence. Whatever it might be that our endpoint is looking, we take all of the data and through ARENE's data science can really pull out what risk factors we're looking for and where we hope to intervene.
That's great. I see folks like between the questions you submitted upon registering and the ones you've been submitting throughout today's discussion, we've had a record number, over 50. At my count, it looks like we have about half unanswered. I apologize. We only had 60 minutes. I did the best I could managing both screens and trying to get all the information out to you. Maybe it bodes for a sequel event down the road. I want to thank all of you. You've been awesome. But the five of you for all the time you spent preparing with me and how great you were in trying to stay on time. I know we had a lot to cover in a short amount of time. So thank you to our panelists. Thank you to all of you listening. Certainly provide us feedback through that feedback form. If you think we need more time, if I didn't get to your question, you could yell at me through the survey. And thank you all. We don't take the hour you spend with us live or through recording lightly. So we do appreciate all of the time you've taken. And this will mark the end of our show. Next week, same on Thursday, we'll be covering we're covering mental health and words matter and preventing suicide and just a better way of communicating with physicians with Kevin Lynch, who's the founder and the CEO of a really cool organization called the Quell Foundation. So look forward to seeing you all here next week. Thank you all again. This will mark the end of our show.
Thank you.